Yes, sir. Good evening, everybody. First of all, thank you, AIOS and Dr. Amit, for giving this opportunity. So today I'm going to talk about failing filter stepwise management. As all we know, the tracheotomy is most commonly performed surgery, and still, despite of so many surgeries, I think it is the still one of the most commonly performed surgery and still gold standard for the surgical management of glaucoma. But the completion of surgery is still the beginning of the healing process that takes several months to complete. It required it required frequent monitoring and to identify the changes in the BLEB and provide a window to opportunity to modulate the BLEB. So what is a successful BLEB? Successful BLEB, it is a quiet, mildly elevated, diffuse, lack of vascularization, and presence of the microcyst, and there should be the IOP should be appropriately controlled. So how to get the such BLEB? There should be some preoperative, intraoperative, and postoperative measure we have to take. So my previous speaker talked about it. So we will concentrate on postoperative measurement. So most crucial step to recognize the early BLEB failure. So how to diagnose early BLEB failure? So always look for the extent of the BLEB, either is a low or flat, and look for the vasculation, either the mild, moderate, or severe, and look for the presence of the corpuscle vessels, because corpuscle vessels is a sign of the initiation of the BLEB failure. Then look for the thickening of BLEB and look for the microcyst. Initial period probably IOP may be the normal or maybe the low, but once the BLEB failure is started, the gradually IOP will rage and the BLEB becomes a less diffuse, vascular, flat, and opalescent. So what is the most common cause of BLEB failure is subconjunctival or episcleral fibrosis, and second most common is subtenant encapsulation. So what is the site where the BLEB mostly fail? Either the BLEB capsule, there is the subconjunctival fibrosis or the episcleral fibrosis. Second cause, either you put the tight BLEB suture or sometimes the flap is fused with the underlying sclera. And secondly, what is the sclerostomy, ostomy image, that is closed. So these are the stepwise management for the topical steroid, distal ocular massage, subconjunctival MMC or 5FU, and release the suture. So I think we will take one by one. Probably this is the same slide. It's repeated. Sorry. So coming to the causes of BLEB failure. Probably this is a fibrin, blood viscoelastic around the ostium, sometimes the tight flap suture, or the early scarring as the main cause of the BLEB failure. So coming to the topical steroid, unlike the cataract surgery, in trabeculotomy, we need the corticosteroid for longer period of time, because the topical corticosteroid decrease the wound healing as well as maintain the open fistula, while the cycloplegic decrease the inflammation as well helps in the deepening of the anterior chamber. Sometimes the topical corticosteroid required for 3 months, even the more than 3 months also. Then coming to the distal ocular pressure, probably this is the most underrated maneuver in the post-operative management, but is very, very helpful, especially in the first 2 weeks of the surgery. So how we do the distal ocular massage? We can press or apply the pressure under inferior fornix in the sclera or adjacent to the flap. And some of the surgeons use the cotton tip applicator. So see in this video. So gently, I used to do all my ocular massage under the slit lamp. So pressing the inferior part, and you see nicely elevated BLEB is elevated. And this is BLEB is elevated. We can wait for some time. We can give the steroid and avoid the suture lysis in early period. Then coming to 5-fluorouracil, it helps in reviving or restoring the BLEB function. 5-fluorouracil enhance the filtration and early postoperative failure. 5 mg, total dose is 5 mg and 0.1 ml of 50 mg can be given. Usually it can be given 3 to 10 injection and within the first 2 to 3 weeks. We used usually 30 gauge needle. Previously, most surgeons used to give the 180 degree away from the limbus, but recently most of the surgeons use the 5FU adjacent to the BLEB or above the BLEB. Only things we have to keep in mind: the 5FU is highly epitheliotoxic, so you should avoid any spill during the injection. Then coming to the laser suture lysis, when we find out our BLEB is failure due to the tight suture, we can perform the suture lysis. It's helpful, especially in the first month of surgery when we are not using antimetabolite. Once we are using antimetabolite, we can do up to the 6 to 8 weeks. These are the various lens can be used. Most commonly lens used is the Hoskins lens. and we can use the power of 200 to 500 milliwatt, exposure time 0.1, and spot size 50 micron. So this is, you can see in this video, this is first localize the BLEB, localize the suture. After localizing the suture, just you cut the suture. After the cutting suture, if BLEB form spontaneously, then nothing to do. But most of the time, if BLEB doesn't form, then it's essential to do the ocular massage. If you don't do ocular massage, just you cut the suture, it doesn't make solve your purpose. Then coming to religible suture, if you don't have the facility of green laser, some people use the religible suture, either the one religible suture or two religible suture, and the suture has to be released within a month. So again, see on the set lamp, just you have to pull out with the forceps, just you pull out, and the suture has come out. If it's black form, well and good. If it didn't form, then again you have to do the ocular massage. And whenever ostium is closed by the incarceration of iris, vitreous, or dense membrane, or enfolding of the dense membrane, we can consider the laser disruption. Most commonly use the anti-arc laser. Then, if all our conservative measurement, like the episcleral scarring is set, all the ALS has been done, ocular massage, steroid, everything is going to fail, then we consider the BLEB needling. So these are the various technique of the BLEB needling. Either we can do in slit lamp, or we can in the option theater. I personally recommend we have to start with the option theater, because we have more control in our hand. And once you expert in the option theater, then we should go do into the OPD procedure you can do. So see this video. First I'm injecting the mitomycin C. After injecting mitomycin C, just I'm pulling away pulling this mitomycin away from the BLEB area. Then 30 gauge needle is bent. After bending the needle, this needle is passed away 5 to 6 feet away from the limbus, and the BLEB needle contour has to be follow the globe, and slide this needle under the flap and throw the under the flap. We slit under the flap, then we can go into the anterior chamber. Once we enter the anterior chamber, our globe becomes soft. They can appreciate with your traction suture and the end point of the BLEB needling. And similarly, this video I am using just AC mentor because it's a faking patient, and this faking patient, because an AC entry has to be, we should not be done in such cases when we are using doing BLEB needling in the fake cases. I think these are the other BLEB needling technique. We can use the Grover spatula, and this BLEB needling we can do in the like OPD. We can do the BLEB needling, and these are some complications of the BLEB needling. And BLEB needling can rescue the failing BLEB, save the patient burden of using multiple glaucoma medication and repeat surgery. So most important, early diagnosis and management of the BLEB is very crucial. If always look for the every time BLEB extent, BLEB height, BLEB vascularity, corpus basalt, and microcyst of the vessels, then we get the nice successful BLEB, and we have the successful trabeculectomy. Thank you. Kind attention.